So coming to the third presentation today in this first section, which is about opioid toxicity. My name is Sarman Salvin, and I'm a third-year emergency resident. So it's my ultimate pleasure to be part of this symposium to talk about one of the favorite tox drug, not only to you, but also to the drug addict, which is opioid. So I have no conflict of interest. So by the end of this small talk, will be covered the approach to patients with opioid overdose. We'll be discussing about acute management of opioid overdose in summary, and to be familiar with common fears and pitfalls in opioid overdose. If you have any questions, the discussion panel will be at the end of this presentation. So we'll start with this case scenario. A 30-year-old female dropped off the front of your health center. Nobody was accompanying the patient. Two of your nurses rushed and shifted the patient to the recess. The patient is unresponsive, limp, cyanotic. She's breathing shallowly. Vital signs: her heart rate is 106, BP is 96/64, her temperature is around 57, and her respiratory rate is 6 breaths per minute, and her saturation is 89. So further examination revealed pinpoint pupils, needle tracks in both antecubital foci, multiple abscesses and bruises in various stages of the healing. Her skin turgor is poor with signs of malnutrition and dehydration. So now I brought this case, and you definitely know the diagnosis based on my first slides. However, what I hate to tell you, the clinical presentation, is it gonna be easy, like straightforward? So before running into solving this case, let's just chat about opioids. So opioids are the most common abused prescription drug worldwide. It is, so there are different types. There are the synthetic and there are the natural. It's naturally coming from the plants which called opium poppy. So this is actually where the opiate medication start from. But there are also different types of opioids. And it's crucial to know about the kinetics and the types of the opioid, because it will alter actually the management, it will alter the clinical presentation, and also the level of the toxicity. So in particular, like for example, the fentanyl, it's actually almost 100% more, 100 times more potent than the morphine. The morphine is considered the fastest and short-acting one. Also, if you look at the methadone, for example, it has the longest half-life, so from 15 to 40 hours half-life. It means it will have a prolonged toxicity course, which will need more management. So let's first jump into some pathophysiology. So actually, how opioids actually works? It's actually, there is some receptors in your brain which is called the mu opioid receptor. The opioid actually binds to these receptors. Generally, the calcium channel should open and the potassium channel should close in order for the neuron to pass an action potential. But what happens when the opioids bind to the mu receptor, it happens the opposite. The calcium channel closes and the potassium channel opens, so the action potential will be less likely to fire. Now, how opioids get you high? Basically, when the binding of the opioids happen to the mu receptors, there will be decrease in the GABA release, and the GABA will cause the dopamine surge, which is responsible for the euphoria feeling. But it's very important to know that it's not always the triangle that we all know about the opioid overdose, which is the conscious, at the level of consciousness, respiratory depression, and the pinpoint. There are some medications that actually don't have the triangle. Like for example, you have the clonidine. It's actually an opioid mimics, but it can also cause opioids. Sorry, the meiosis. Now, always keep your differential white. Keep in your mind the AO tips, which is the differential diagnosis of altered mental status. And I always like this phrase ABCDEFG in toxicology, which is ABC, which is the management, the supportive management, and then don't ever forget glucose. You will be surprised by the amount of detox medications that can actually alter your glucose. Now, the opioid toxidorm, so memorized by the CPR3H, it's coma, pinpoint, pupil respiratory depression, hypotension, hypothermia, and hyporeflexia. Right? Right. Now, increased opioid tox may actually also see with concomitant use of sedative hypnotics, which will give more opioid toxicity. Also, on those patients with pre-existing pulmonary disorders. Always consider co-ingestions with any toxicology. Like, for example, the most common ones are actually the salicylates, the aspirin, as well as the acetaminophen. So always check for these and suspect it in any toxicology case. Urine dextrine actually can be obtained, but it has little, if any, clinical utility. It has no point to actually even doing it. Now, I would like to focus on 3 key features to understand opioid toxicity. One is opioid overdose can have a life-threatening toxic effect, multiple organ system like rhabdomyolysis, like the pulmonary edema, and so on. Normal pharmacokinetics properties are often disrupted during an overdose and can be prolonged intoxication dramatically. The variability in the duration of action, as we mentioned in the kinetics, can have an inappropriate treatment decisions and lethal results. Now, let's back to our case. So how would you actually manage this case? Just like any emergency approach, which is the ABC, support the airway, as you saw in the presentation of my colleague Musna. So airway breathing, if the patient is apneic or need apneic, do back valve mask ventilation. Supplemental oxygen, keep your saturation more than 92. All right, and then I will jump into the naloxone in the next slide. So just keep this, and always consider possible congestions. Now, investigations, so blood sugar, ABG, CBC. Check the CK for the rhabdomyolysis, LFT, and urine electrolytes. And definitely, as I said, the congestion, the paracetamol and salicylate, are, if any others are suspected. ECG is crucial in opiates toxicity, because there are some medications of opiates that actually cause arrhythmias as well as prolonged QT. So always do an ECG early. Pregnancy test for women with childbearing age. Now, I would like to start by this, actually, about the naloxone. The naloxone is a specific competitive opioid antagonist. The goal of giving the antidote is actually to restore the adequate spontaneous ventilation plus minus the mental status. But the main goal is actually to establish the spontaneous ventilation. It can also aid in diagnosis of opioid overdose based on the rapid effect of the naloxone. It has a very short half-life, and I will be speaking about this. It can be given in all the routes, but the oral, because of the bioavailability. Now, I would like to focus on this slide, because this is the most important slide in my presentation. Is that so the naloxone, how much to give? Actually, we can start with a short dose, small dose, like 0.04 IV, and then we can titrate up to 6 to 8 milligram. During the so it can also, the boluses can be repeated, encouraged up to 10 or 15 milligram. If any recurrent respiratory depression happened during the initial dose, after the initial dose, you can start the infusion, which is actually 2/3 of the effective dose that you give. So as I said, it has a rapid effect, can aid in the diagnosis. You can have some exceptions to increase the dose, like in the arrest or near arrest situations. The chronic opioids users, be careful with them, because you should actually use the minimal effective dose to avoid withdrawal. High doses and long-acting opioids like and also the massive overdoses and potent opioids like fentanyl. Also opioid mimics like clonidine. Be careful of precipitate opioid withdrawal, because it's actually self-limiting, but it can also have rarely some arrhythmias. So if you started the infusion and the patient started to have some withdrawal symptoms, stop the infusion until the symptom resolve, and then restart at half the initial rate. So the other ways of management to activate charcoal. So not really, there is no data to support actually the usefulness of sustained release. The risk of charcoal aspiration should also be in mind because of the altered mental status. Whole bowel irrigation, not generally useful as well, can be considered in body packers. Hemodialysis, there is no role of enhanced elimination due to the large volume of the distribution in the body for the opioids. So it's mainly about you have a golden antidote, which is enough. So now disposition. Asymptomatic, be aware of delayed following narcotic overdose. Observe patients for 4 hours. For symptomatic patients, more prolonged observation they need, and observation for 12 hours. All right. So, like if you're in the health center and you do have like an opioid overdose who is actually asymptomatic, and he's like, and you observe him for like 4 hours without any symptoms, and you did all the other investigations like ECG and that, and there's nothing, you can observe and then discharge. But definitely, if you have any like symptoms, if you have any clue, or even if you suspect that this patient will deteriorate, then definitely has to go to the emergency department. Now, the prevention is the best cure. So in some countries, there was actually the community naloxone programs where they deliver the naloxone to certain people. And also, we need to monitor the prescription drugs. So in summary, opioid stocks can lead to serious toxicity in multiple organ systems. Always consider possible congestions and manage accordingly. ABC, early naloxone, is your cornerstone of managing opioid tox. And observe a symptomatic patient for 4 hours, symptomatic for 12 hours. Right. So these are my references. You can go to our guidelines of poisoning, right? And thank you so much. So now we are moving to the discussion panel. If you have any question for me, for Dr. Muzna, and for Dr. Alia, please type it in the Q&A section, and we'll be very happy to answer.